Welcome everyone to Implementing Supportive Care for the Dialysis Patient with Dr. Daniel Lam. I'm Sherry Sliwa, Coordinator for the Coalition for Supportive Care of Kidney Patients. This is our fifth webinar in our series on supportive care and nephrology. This series is intended to complement a series of articles that Nephrology News and Issues is currently running. Dr. Dan Lam's article will be published in next month's issue. Before we begin, just a few housekeeping items. For clear reception, attendee lines have been muted. We encourage questions throughout the webinar and ask that you use the chat feature on the right side of your screen to submit questions. When submitting a question via chat, type your comments and questions in the text box, choose All Participants, and press Enter. We will attempt to answer all questions during the presentation, as we may not have time for questions at the end of the presentation, though we have kept some space open for that as well. At the end of the webinar, as you close your webinar screen, you should receive a pop-up evaluation. Please fill this out as we greatly appreciate your feedback. And finally, all webinars are recorded and will be posted to the Coalition website at kidneysupportivecare.org within a few weeks. Dr. Alvin Moss and Dr. Dale Lupu are serving as our moderators today. Dr. Moss is Professor of Medicine in the sections of Nephrology and Palliative Medicine at the West Virginia University School of Medicine. He serves as chair of the Coalition for Supportive Care of Kidney Patients. Dr. Lupu currently holds an appointment in the George Washington School of Nursing, where she is on faculty of the Center on Aging, Health, and Humanities. Dr. Lupu and Dr. Moss are co-principal investigators on the Pathways Project, a more foundation-funded project to integrate supportive care into the treatment of patients with advanced CKD and ESRD. And now I'm going to turn things over to Dr. Moss.
Thank you, Sherry. Let me introduce our speaker, Dr. Dan Lam. He is a nephrologist and palliative care physician and a clinical assistant professor of medicine at the University of Washington in Seattle. He practices at Harborview Medical Center, where he is also the medical director of their palliative care service. In addition, he directs the Mobile Renal Supportive Care Team at Northwest Kidney Centers. This is the nation's first mobile kidney palliative care team aimed at serving the palliative care needs of dialysis patients. I'm pleased that Dan is our presenter today. He is a real innovator. He in the past has won a Sojourn Scholar Leadership Award to really innovate with regard to palliative care delivery in this country, and we're fortunate that his efforts are really, they've really been concerted towards improving the care of dialysis patients, and that will be his topic for today. Let me turn it over to Dr. Dan Lam.
Thank you so much, Woody, and thank you so much, Sherry, for having me. I'm really thrilled to be here to be talking with all of you about implementing supportive care for the dialysis patient. And really, I'd like to generate a conversation, and I've left time at the very end for all of us to talk about, ask questions, share our experiences, even what our organizations and we ourselves might be thinking about, because I think that this is a space that is really ripe for innovation, ripe for learning from one another, so that we can do better for our patients moving forward. All right. So I have no disclosures. And so as we begin, I think one of the key questions here is, how do we seamlessly integrate palliative care delivery throughout the entire continuum of advanced kidney disease? As many of you know, palliative care is for anyone with serious illness, and this would certainly include, by definition, anyone with advanced kidney disease and anyone with end-stage kidney disease who is on some form of dialysis. Palliative care can be delivered alongside disease-directed therapies, such as dialysis. And yet, at the same time, how do we better access palliative care services for our patients? So today, I have three objectives. One, to identify patient, family, and system drivers for kidney palliative care. Number two, describe our experience here at Northwest Kidney Centers of our mobile renal supportive care team. And then thirdly, to relate one element of our story to your local context. Every local context is different, And I hope that there will be something in my talk here today where you'll be able to take an element and think about how that might apply to your context. So we know that patients and families with serious illness, and certainly patients and families with end-stage kidney disease, face significant stress and symptoms. And kidney palliative care is an extra layer of support to address these stressors, these symptoms of advanced kidney disease. The two main needs that we're talking about are symptom management and advanced care planning, so that we can help people write the stories that are most important to them, to take control over the uncertainties that come alongside facing serious illness. And we know that the symptom burden of end-stage kidney disease patients is quite high. It's akin to those patients with advanced cancer, on average anywhere between 9 and 12 symptoms. And I'm glad that finally we're seeing some abstracts and papers like this where the conversation is starting to shift from not only describing the burden of symptoms. We know that the burden is high. There are many, many papers talking about that. And now shifting towards, well, what are the symptoms should we prioritize, and what are the interventions that might be meaningful for our patients and families? And at the same time, one challenge is this area around advanced care planning. We talk a lot in the dialysis community around keeping people from crashing onto dialysis, making sure that they have timely referrals to nephrology, are guided through questions around whether or not dialysis is right for them, having access to active medical management without dialysis, having education around modality selection, if dialysis is the right thing for them, vascular access planning, et cetera, et cetera. And yet at the same time, what we do know is that patients are also crashing off of dialysis. And I'll show some data around this. Many of you may be aware of this data. This data is a little older than 5 years now, and really looked at the intensity of healthcare in the last month of life for patients who are on maintenance dialysis older than 65 years of age. And they compared them to patients with advanced cancer and advanced heart failure, and on virtually every metric, patients who are on dialysis had more hospitalizations, spent more time in the ICU, had more intensive procedures performed, less hospice use, and more death in the hospital compared to their counterparts with advanced cancer and advanced heart failure. And you might say, well, perhaps for one individual patient, their values may have prioritized longevity over comfort, but I think when we're looking at on a population basis, that's a harder argument to make. So it really begs the question, what could we be doing better? When we also look at advanced directives for nursing home residents who are receiving maintenance dialysis, we see a similar kind of a pattern where arguably these conversations aren't happening, or the quality of these conversations is not great. So in the dark blue bar, these represents end-stage kidney disease patients. The slightly lighter blue, cancer, and then the kind of slightly lighter blue after that, oxygen-dependent COPD, so advanced COPD, and then the lightest blue, advanced dementia. And you can see that on every metric, having some form of advanced directive doesn't really reflect necessarily the quality of that advanced directive, having treatment preferences articulated, having a treatment-limiting directive, naming a surrogate even, so that you would think is low-lying fruit, and having both the treatment-limiting and directive and surrogate. End-stage kidney disease patients who are on maintenance dialysis and in a nursing facility have less rates of these kinds of metrics done compared to their counterparts with cancer and COPD and advanced dementia. And really not much has changed in the last 10 years. Under Carla Tamura and her group looked at about 150,000 nursing home residents who are on dialysis and linked data from the USRDS to Medicare claims data and the minimum data set, and looked at healthcare utilization in the last month of life, last month of the last year of life. And you can see on the very left-hand figure, the light blue represents the year 2000 and the teal 2010. And just graphically, you can see that not much has changed in terms of having a surrogate, having some kind of treatment-limiting directive, or having a treatment-limiting directive and a surrogate. The vast majority, as you can see here, do not have anything documented. And on the right side, you can see that healthcare utilization in the last month of life has increased from 2000 to 2010. And this is even despite having these treatment-limiting directives in place. Although certainly, it's, as you can see, it's helpful to have them in place. So what is this really all about? It's about having a conversation that empowers our patients and families to prioritize what is most important to them. Again, to write the stories that are most important to them. And importantly, this is not about one conversation, but really a series of conversations with not only the patient, but their entire community, the people who are going to be supporting them with decision making. So what do patients and families want? What do they see in terms of their experience with advanced care planning? And so this is a study, kind of qualitative study of dialysis patients and their families looking at exactly this question. Number one, as we know, as we can see from some of the quantitative data and what it's inferring, it rarely occurs. And that's certainly what the qualitative data is suggesting as well. Patients and families recommend starting this conversation early and incorporating this as part of routine care, not just at the end of life, and reinforce the importance of family involvement. And that makes sense from a practical perspective. You know, if there's a patient who is unable to make decisions because of delirium related to an acute event, if a family member who is the designated surrogate does not know, has not been involved in conversations, how are they going to be confident in moving forward? Trust is key, and that seems to be a no-brainer, but it's especially important in marginalized communities, in patients with lower socioeconomic status and minorities. You know, they're bringing this whole story of being disenfranchised from the healthcare system even before the point of contact where they've, you know, initiated dialysis, for example. And so it's important to be giving ourselves enough time to develop that trust. And of course, nephrologist involvement is really desired by these patients and families. I think this quote from a patient really sums it up. It says, "I think that discussion should come before you get to the critical point. At the jump of a dime, things could turn. So I think the more prepared you are, the better you could handle things." I really don't think you could say it any better than that. And so just take an analogy from retirement planning. You know, the message is you need to do this early. You can't do it just the day before you retire. You're just not going to be prepared. And you know, that is exactly what's happening with our patients and families right now when it comes to advanced care planning. People say, oh, you know, we have inpatient palliative care services at our hospital. You know, we consult them in the intensive care unit. We consult them when they're hospitalized in acute care. And that is a very good thing. I work on the inpatient palliative care service as well. I think it's important to have that service. But that is essentially like having our patients, you know, prepare for retirement when they're 64. So we also know that advanced care planning is not going away. CMS thinks so, and for those of you who are involved in ESCOs or end-stage renal disease seamless care organizations, essentially accountable care organizations in the dialysis context, we know that advanced care planning is part of the quality measure set. I also think that it's important to realize why advanced care planning is there. Again, it's about creating the conditions, encouraging the conditions for goal concordant care, and not just a checkbox, to make sure that we are helping people to prioritize what's most important to them in a dynamic fashion as their disease trajectory unfolds. So really, let's not reduce advanced care planning to box checking. I think one of the things that CMS has done in changing the definition of the metric that I'm certainly encouraged by is this change to include oral statements around desires for future care, what patients and families may prioritize in that setting. Because again, it's a series of conversations. It's not just about filling out an advanced directive that may be meaningless and not really tailored to what's most important to patients and families. Instead, it really needs to encapsulate their stories, the themes in their stories, and what they're going to be prioritizing over time. So, as we think about this, it might feel daunting, and I want to acknowledge that, and I certainly feel that at times. It is a tall task to complete when you're looking at it from a healthcare system perspective. So what are the broad concepts in terms of a strategy to address this issue? This concept of primary palliative care, or really the basic skills that all providers should have, that all kidney care professionals across disciplines is really important. There are only so many specialty palliative care providers to go around. To just give an example, there's one palliative care physician where every 1,200 patients with chronic serious illness, there just is not going to be the capacity to address every single person's needs with specialty palliative care, and that's why we need to improve everyone's basic skill set tailored to that discipline. So when we're thinking about a dialysis provider, we're looking at not only the nephrologist, but also everyone who's part of the interdisciplinary team. You're looking at your social worker and nurse and dialysis technician and dietitian, and ideally you'd also be involving administrators, receptionists, etc. So before I talk about our program, I want to introduce a real patient that our renal supportive care team saw. This is patient R.A. She's a 90-year-old fierce matriarch. She's a grandmother to another dialysis patient who has kidney failure from autoimmune disease. She's been on dialysis now for 6 years, dialyzing in-center. And we got involved after she was diagnosed with a new more than 2 centimeter lung mass, likely a malignancy. She's been living independently, independent of all her ADLs. She lives with one of her 3 daughters, really enjoying life at this point in time with her family and her kids. She's one of the favorites of the dialysis staff in the unit that she's been in for the last 6 years. And her primary care provider has been a real model for primary palliative care. She's engaged this patient in advanced care planning. It's been a series of conversations where the patient has consistently prioritized comfort over longevity, really prioritizing being at home with her family, and she's declined further workup of her lung mass at this point in time. She said, "I've lived a good life. I know this is likely cancer," and she really doesn't want to undergo additional procedures just to confirm that. And so why are we involved? Because the family dynamics are complex. The patient and daughter don't really see eye to eye. In fact, she's acquiesced to one of her daughter's wishes to remain full code just because, her daughter is really in a place that's different from her in terms of accepting, her mortality and sort of where things are headed from a health perspective. So we get involved, and we're not addressing code status right away. That's in our minds, not really going to be most productive. So what can they agree on? What's the story? What's the thread that is most important? Well, she's been living in this home for many, 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 many years. It's not just a building. It's a place of real importance. And so being at home is very important to her. Maximizing her independence is also very, very important, for her. Being able to do things on her own constitutes a level of dignity that is very important to her. And of course, spending time with her family, her kids, her grandkids, and her great-grandkids is very, very important to her. And she is recognizing her own mortality. And as she thinks about that, physical comfort is also very important to her. And, as we get this out on the table with her daughters, they are all in agreement with this story, that these are the things that are most important to her. And so I want to leave you with this question as I then pivot to talking about what we're doing at Northwest Kidney Centers. What can we do to help her succeed at home for as long as possible? So what can we do to help her succeed at home for as long as possible? So, our mobile renal supportive care team is embedded within a dialysis provider, Northwest Kidney Centers. Many of you probably know this already. Northwest Kidney Centers is the birthplace for chronic hemodialysis, and it's a nonprofit dialysis provider that serves 18 clinics in the Washington State region and about 1,800 patients throughout the state, primarily in the Seattle and greater Seattle area. And like many of you, we deal with a fragmented healthcare system where patients are coming from multiple healthcare systems, from multiple nephrology physician groups that are affiliated with some but not all healthcare systems, where patients are accessing their subspecialists and primary care from different healthcare systems than their primary nephrologist. They may be seeing a cardiologist or primary care provider or endocrinologist in a different healthcare system than their own. And it's an open staffing concept, meaning that there are many different nephrologists that are sending their patients to different units. So there's not one nephrologist at one unit. There needs to be care coordination amongst many different healthcare systems, many different providers. And so a couple of years ago, this opportunity arose when Northwest Kidney Centers was embarking on starting an ESCO, or End-Stage Renal Disease Seamless Care Organization, again, essentially an ACO for dialysis patients. And it launched in January 2017 and covers about 600 plus beneficiaries across 6 different clinics, 3 in the downtown area, as you can see here, in other areas north of Seattle, south of Seattle, on the east side, and encompasses both in-center hemodialysis patients as well as our home patients on home hemo or peritoneal dialysis. And so this is the evolution of our program. Actually, before the ESCO even started, we were thinking about, well, how do we better integrate palliative care services for our dialysis patients? And the initial idea was, well, let's connect patients to outpatient palliative care within their own healthcare system. The problem with that was there are some healthcare systems that don't have outpatient palliative care. They might have an inpatient team, but they did not have outpatient palliative care. And while that's grown, there are still some healthcare systems that lack access to outpatient palliative care. Frequently, and certainly at that time, the scope did not include dialysis patients. So, for example, some of these clinics were embedded within a cancer center. And so access for dialysis patients was was not available unless those patients had some kind of concurrent cancer and receiving cancer treatment at that healthcare system. And finally, the burden of clinic visits. So some of the remaining outpatient palliative care programs that were there, many of those operations or many of those clinics did not include the ability to see patients in the dialysis unit or at home. And so patients who had difficulty already seeing their primary nephrologist and other subspecialists just could not handle the additional burden of clinic visit, which makes a lot of sense when you're thinking about the lived experience of the in-center hemodialysis patient spending 12 hours just at dialysis, excluding transportation, et cetera. So out of this idea was, or out of this sort of needs assessment and sort of gathering of information around what was available from an outpatient palliative care standpoint, we decided it's really important to meet people where they are and meet people geographically where they are as well. And so we constructed a mobile renal supportive care team of a part-time physician, myself, and full-time social worker and full-time nurse. And I really want to give a huge shout out and just a ton of credit to my teammates who have really made all of this possible. Claire Nazzuti, who was the first person hired, she's our specialty level palliative care social worker, and then Megan Nolan, who is our specialty level palliative care nurse, both of whom had quite the sort of prior training in a county hospital burn intensive care unit. So they had opportunities to practice primary palliative care. And at the same time, we were able to secure funding from the Kidney Center to help train our providers in to give more formal didactic training in specialty level palliative care. So initially, we were piloted to some of the units in the downtown area, and about a year later, we expanded to all of the ESCO units in the greater Seattle area, and have seen folks in the home and nursing facility, adult family home settings as well. And initially, we had a screening process for specialty kidney palliative care. We had an EMR-based trigger just to be a starting point for a conversation with our dialysis staff. So this was a list that would screen patients on a monthly basis. This list was reviewed with our dialysis staff. Dialysis staff could also have input around patients who would be appropriate. As you can imagine, we have said that palliative care is appropriate for anyone with chronic serious illness, and that would really encompass all patients with end-stage kidney disease. And then I would call the primary nephrologist to get final approval on whether or not renal supportive care would be involved. And this is just to ensure that nephrologists are involved in the entire process, and the patients would then be seen by our team. And over time, the process has changed a bit. Our electronic medical record is, let's just, shall we say, not the greatest. And, we made a strategic decision around, how do we better involve our dialysis staff? There were certainly patients that were really causing staff a degree of moral distress. And instead of just having this kind of pseudo buy-in from our dialysis staff, we really wanted them to start to own the process a bit more. And so they are, and certainly in our downtown units, really involved with selecting patients for nephrologist approval. I wish that we had one or just a couple of nephrologists at each dialysis unit, but really we're looking at the majority of nephrologists in the Seattle region sending their patients to these various units. And so that's been a bit of a challenge, but we have, been able to identify early adopters. So nephrologists who have maybe initially gone through this process, have had a healthy dose of skepticism. We've worked with some of their patients. There have been, good outcomes, kind of all the way around from patient and family perspective, most importantly, from the dialysis staff and primary nephrologist perspective, to the point where, primary nephrologists are now sending their patients to us first. And so this is some sort of unpublished data that we presented at CAPC, looking at some of our advanced care planning outcomes. So this, on the left-hand side, this is patients who are just willing to engage in some form of advanced care planning, even superficially. And you can see that the majority of people are willing to engage on some level, if even at least to explain the process, and to normalize this as part of routine care. So 97% of our patients, in terms of completing one key piece of advanced care planning, defined as having a PULSE filled out for patients whose care preferences dictate limiting aggressive measures. So in my view, a PULSE where your full code and prioritizing longevity over all else, I don't think that that's necessarily the best use of someone's time, because that is the medical default. But if someone has articulated care preferences that dictate limiting those aggressive measures, that should be codified in a PULSE form. Also, documented goals of care, and this is part of the Measuring What Matters from one of the National Palliative Care organizations. Completing some form of an advanced directive, and in my view, an advanced directive that is not just done as a checkbox, but again, that articulates patient and family priorities. And lastly, establishing a preferred surrogate decision maker, also very important. So 90% of patients whom we saw were able to do that and were willing to do that as well. So back to our patient, all right. So it's great to have that conversation. We were able to get a sense of what's most important, and the question was around how do we support her at home, and what are her care needs. So as we were discussing this over several visits, access to symptom management at home, including 24/7 access to symptom management expertise, as her health trajectory was expected to worsen, that was seen as very important, not only by our team, but by the patient and her family members. Having support, both psychological, emotional, and spiritual, in the home setting was important as well, and future access to home health aides. She's able to perform her own ADLs, doesn't need really much help from her daughters at this point in time, but anticipated a point in time where this would be really helpful to keep her in the place that was most important to her. And some of you may be thinking, well, what is that infrastructure that provides all of that? That sounds a lot like hospice. And in fact, that's exactly what hospice can provide. And so as we were explaining just the services themselves and then connecting it to hospice, that she may be able to get hospice alongside dialysis because she would have a non-kidney related hospice diagnosis, they're all accepting of a hospice referral. And at the same time, because of our experience with hospice, we prepared them that they may say, you'd have to stop dialysis, et cetera, but they were very much on board with receiving such a healthcare service in the home setting to keep her at home. And so, I want to liken this a bit to, our the current way people shop. People want things delivered to their doorstep, and you can imagine when someone is facing chronic serious illness, and certainly towards the end of life, it's that much more important to be receiving healthcare services in the home setting. And what is the infrastructure that provides that? Well, it's hospice services, if you're able to qualify for that. And so that's been a part of what we've been doing as well, is getting people the services that they need, certainly at the end of life. I do wish that the kind of infrastructure that hospice provides is available further upstream, but we're sort of dealing with what is available right now. And so this is some data from our decedents over approximately a little more than a 1.5 year period of time. In this very light blue here, this reflects the published data around Medicare beneficiaries who receive hemodialysis, or not hemodialysis, just dialysis in general, and whether or not they're receiving hospice at the time of death. So this is, even if your hospice length of stay is 1 day, you'd be included in this. And so 20% of dialysis patients receive hospice at the end of life. And of course, there are policy barriers that make this more challenging, which is why I think that we're not seeing more robust hospice utilization. And even with our team, we're able to increase it. The Washington State has a much lower sort of hospice utilization than the national average. I don't know what it is. We don't know the exact numbers for dialysis patients, but it certainly would be less than 20%. And we were able to increase this to 33, 35-ish% for our patients. And of those, about 10% are receiving concurrent hospice and dialysis. And so this is a bit of a scatter plot of our patients and their length of stay. And patients who have this kind of light blue bar, these are folks who were able to receive concurrent hemodialysis for a period of time, with the mean hospice length of stay 23 days and a median of about 11 days on hospice. And I want to connect this to a study that Melissa Wachterman published regarding hospice lengths of stay and Medicare costs, as well as end-of-life costs at the end of life. And so as you can see here, the white bar is patients who were on dialysis who did not receive any hospice at the end of life. This beige color, less than 3 days. Blue, 4 to 7. This darker, almost brown color, 8 to 14 days, and this teal color, more than 15 days. I'm going to draw your attention to adjusted mean costs that were paid out by Medicare in the last week of life. It really reflects healthcare utilization overall. So patients who did not have any hospice had cost around $11,000, and this was similar to patients who were on hospice for less than 3 days. And that makes a lot of sense to me. These are probably patients who are being discharged from the intensive care unit or, from acute care, either to home or to a general inpatient. So it's a hospice designation that might benefit the hospital, but in actuality, patients are not really receiving, a significant amount of care in the home setting. For patients who are receiving hospice even 4 to 7 days, they're probably stopping dialysis, perhaps as an outpatient, or had kind of less of an acute inpatient event and stopping dialysis at that point in time, maybe have some residual kidney function. These are patients whose costs at the last week of life were about $6,000. And then if you have people on for more than a week, you're looking at costs of about $3,000 in the last week of life. So we can see that there's this, in terms of this term that we hear a lot, achieving the triple aim of improving patient experience and decreasing the cost of care and improving outcomes, at least when we're looking at end-of-life outcomes. Improving hospice access for patients is going to be a piece of that puzzle. So back to our case, what happened to our patient RA? Well, unfortunately, she was scared by hospice. They did tell her she'd have to stop dialysis despite our warnings, and it scared the family, and they really were not ready to enroll in hospice at that point in time, although we've had some success in escalating things up the chain to the hospice medical directors and above for patients who really, from a Medicare standpoint, are eligible for concurrent hospice and dialysis. This critically, for her case, dialysis was affording an acceptable quality of life. She was able to do all those things at home and still able to live independently at that point in time. So unfortunately, she missed 2.5 months of hospice services in her home. She developed worsening malignant pleural effusion and was then hospitalized for worsening dyspnea. And eventually, with a little bit of wrangling, or a lot of wrangling, we were able to get hospice services for her in the home setting. And she was able to dialyze for a period of time while she was able to meet her goals, and eventually passed away after she stopped dialysis with hospice services surrounded by family. As I want to direct you to some of the policy issues that we are contending with. This is an editorial by Vanessa Grubbs detailing the barriers, a lot of which we have experienced in our own mobile renal supportive care program. That it's not just an issue around eligibility for hospice. There is a need for us to be partnering with and educating our hospice providers around this idea of, for patients where dialysis and hospice is potentially available and dialysis is affording an acceptable quality of life, to be able to help our hospice colleagues re-look at their philosophy, because oftentimes there is this binary perspective that hospice and dialysis are like oil and water. They really shouldn't go together at all under any circumstances. This is somewhat perpetuated by the financial issues because of the way hospice is paid for, and also the way hospice organizations are reimbursed. So even if patients are potentially eligible for both hospice and dialysis, and hospice organizations can be reimbursed, they are reimbursed after the fact, after they've provided these services. And each region in the United States has their own Medicare administrative contractors, and in our region there's this, and I think across the United States as well, there's this fear around regulators and what's going to happen. So oftentimes hospice organizations are trying to protect themselves financially just by not accepting these patients. So what are some of the next steps from a systems perspective? We are engaged in establishing more formal partnerships, both from a clinical perspective as well as contractual relationships with hospice organizations. We're really taking a page out of what DCI is doing and what they have done with partnering with a hospice organization to provide limited concurrent hospice for their dialysis patients, to ease the landing, so to speak, for patients who are at the end of life. And then we're also developing a primary palliative care strategy. We have some time because our organization is currently in the midst of an electronic medical record transition, which will be a significant transition as we think about the future and how primary palliative care will be playing a role. So again, I'm going to leave you with this question for your local context. How do I seamlessly integrate palliative care delivery throughout the continuum of advanced kidney disease? And I'll sort of summarize where we were before and where Northwest Kidney Centers is now, and what we're looking to do in the future. So in the past, we did not have any systematic way of accessing palliative care for our patients. If anything, it was done in the hospital alone. We've developed systematic screening, which we will now think about adapting to the new EMR. Once the new EMR is rolled out, we've involved both nephrologists and dialysis staff, created a specialty level palliative care team that is now a specialty service and resource for our patients, nephrologists, and dialysis staff within ESCO units. We're also doing essentially what you might think of electronic consults for patients outside of our ESCO units, where they'll present their patient and the specific issue, and we'll give some feedback on what to do next. Where possible, we have also utilized other outpatient palliative care programs and partnered and are beginning the partnership with hospice organizations to address some of these needs. And we're starting primary palliative care education and thinking about our strategy for the entire organization. One piece of that strategy is that we're the first dialysis organization to join CAPC. So this is the Center to Advance Palliative Care. There are many healthcare systems that are part of CAPC, and it provides a lot of excellent educational resources that you can leverage to provide primary palliative care education for staff, really with the aspirational goal of developing institutional competency across the organization for primary palliative care, one dialysis unit at a time. So with that, I want to thank you. Again, none of this would be possible without all of my colleagues here at Northwest Kidney Centers, especially Claire Nizzuti and Megan Nolan, my teammates. I want to especially thank Joyce Jackson, the CEO of Northwest Kidney Centers, Bonnie Collins, who is now retired but was the interim CMO and played a huge role in moving this forward with Joyce Jackson. And I'd also like to thank Suzanne Watnick, our new Chief Medical Officer, Liz McNamara, who is our Chief Nursing Officer, and Arlene Chen, who is the glue that sticks everyone together. So with that, thank you so much. And I want to open up this time to talk about, ask questions of each other, share what your organizations are doing or thinking about doing, and how we as a community can move forward together. Thanks so much.
Thank you, Dr. Lam. We're open for questions that can be submitted through the chat function. Sherry, I don't know if you can unmute the microphones as well. I've only written down 3 questions that I wanted to ask Dr. Lam, but Dale, did you want to go first?
Sure. So Dan, a couple of things. One is, can you tell us a little bit about where the visits are taking place? What proportion are home, what proportion dialysis center? And it wasn't clear if you are actually running an outpatient clinic or not. It's all visits.
Yeah. So the majority of our visits are taking place in the dialysis unit. At the same time, we are being selective around doing home visits, nursing facility visits if a patient is in a nursing facility or an adult family home. And generally, the trigger there is, kind of a watershed family meeting where, surrogate decision makers and or family members need to be involved. And the only way to be involved is to, go to where they are. So it could be, occasionally family members will come to the dialysis unit. We'll have those conferences in a family conference room at the dialysis facility. But yes, the majority of the work is being done in the dialysis unit with a minority of visits in the nursing facility and adult family home setting.
And just a follow-up question. So just the scheduling of those visits, do you schedule them before the session, during, or after? And physically, how are you arranging for privacy to have those visits?
Right. I mean, that's a big thing, right? So when you're saying session, I'm assuming you mean during the dialysis visit?
Yeah, exactly. So are you doing the palliative care consult before, during, or after they're actually receiving dialysis?
All, but the majority would be during the visit. So that's this lead-up time. So, we did some looking back at our data around what's the average number of encounters we're having with our patients, and it's between 7 and 8 is the average number of encounters per patient, and this is occurring over fairly lengthy periods of time, and so there's this lead-up period of normalizing advanced care planning, explaining what it is, getting a sense of what's important to patients and families, their goals and values, and that's all before we're talking about advanced directives or code status or pulse forms. Generally, that work is done, and then we're involving the key players in the patient's and family's life, or in the patient's life, and it's at that point in time when we need more of that privacy that we'll be arranging for visits either before dialysis or after dialysis, or in the home setting, depending on family logistics.
And using a conference room, not chairside.
That's correct. That's correct. So some people are comfortable talking about their values kind of in a general sense chairside, and that's great. We are cognizant that that's not the most private place, but we're able to get a fair amount of work done there that helps set up meetings with kind of more watershed meetings with patients or patients and their family members.
So let me ask if I could. Mary Beth Callahan wrote in a question for you, Dan. She said, what review have you done of the cost of the program as opposed to, are there savings that you're realizing with the program?
Yeah, that's information that we're still needing to get from Medicare with respect to our current patients. So we don't see everyone in the ESCO units. I mean, we don't have enough staff to be able to do that. And that's why we're relying upon our staff to help identify patients. And I think that at some point in the future, we'll be reintroducing, the screening tool again, perhaps on a level. I like the idea of the surprise question. I think it's the challenge with an open staffing from nephrologist standpoint is that there are many different nephrologists to coordinate with regarding that question. There's been so that's a whole nother issue, but I think one place to start, for example, would be patients who are long-term nursing facility, patients who are on dialysis. They might be stable. I think that would be great if they're kind of stable on dialysis, but to engage those folks in advanced care planning earlier.
So another question, Dan. So you presented the data that there really had not been much change in the practices of advanced care planning, the outcomes between 2000 and 2010. And then you actually cited some more recent studies that pretty much reinforced this idea that we're not doing a great job with advanced care planning with our dialysis patients. I'll just ask you to speculate a little bit. What do you think it's going to take to be able to really improve the outcomes with advanced care planning for dialysis patients?
Yeah, that's a good question, Woody. I mean, I would love to hear more about what other people's take are on this as well. My personal opinion on this is that we really need to better align our financial incentives to what goal concordant care might look like. And so there needs to be sort of greater weight on what quality advanced care planning looks like. I think we have to be careful around just adding another checkbox, because it's easy to just force someone to fill out some kind of advanced directive, or, as an example, the new EMR that we're adopting has a checkbox to say patient decline advanced care planning. And so it's very easy to just say, okay, we did it, we addressed it, but that's completely the wrong message around the fact that this is a process that takes time. I think there's Medicare is moving towards value-based models, and these models are going to be changing over time. I think if ESCO 2.0 is able to include late-stage CKD as well as transplantation, I think that would be a big win in terms of being able to better encourage these kinds of conversations.
Okay, good. Now the questions are starting to roll in, so let me ask you a few. One question is, what type of screening were you doing through your electronic medical record to identify patients appropriate for palliative care?
Yeah, it had to do with functional status and comorbidities. There's a lot of the work that's been previously published, based on age, comorbidity, and functional status. We use nursing facility as a surrogate for that, and we're able to cull that from the EMR. Unfortunately, the data is not really entered in our EMR because it doesn't communicate with other EMRs within the surrounding healthcare systems. So, I certainly, when I put my hat on as a nephrologist, I never trust the problem list that's there. And that might be true of your context too, to kind of think about like what would actually be helpful. And that was some of the feedback that we're hearing from our dialysis staff as well. At the same time, I want to point out that when we first started the program, a lot of times people were bringing these patients with a lot of, there's a lot of moral distress around it. These are patients who were essentially imminently dying. And it's really hard, that's the example of the person who, really hasn't prepared and is going to be getting palliative care in an ICU setting. That's essentially what was happening. They're seeing us like once before they get admitted, and then, there's not enough time to have that relationship, to build that relationship and have a more meaningful series of conversations. And that was the lesson that, as it took a few patients to show that to our dialysis staff, and they've been better about identifying patients earlier on. And the same goes with nephrologists as well. So, we're seeing that pattern being repeated at the units that, because we were piloted initially at 3 units, and then we expanded, and we're seeing, each unit has its own different culture, and they need to kind of learn the same lesson as well.
Okay. What tool did you use to assess patients for symptom burden?
Well, that's I would say that our intervention is more advanced care planning based, and the symptom issue where we are, more intimately involved in the care of the patient is for patients who are actively on hospice as well. So they may be concurrently dialyzing at a hospice, and we're making those recommendations. There's some patients where we do help the primary nephrologist, but it has more to do with the fact that we don't have all of the information from the patient's medical records. They're really not up to date in the kidney center medical records. So if you have the ability to do that, I think that would be great, to be able to do, say, an IPOS renal and fill that out and screen patients on a population level. In fact, that's something that we built into our new EMR. I really want to credit my team here for doing that. We have now a way for us to get that information in a way that we weren't able to in our prior EMR.
Yeah, I've even heard of some dialysis centers where before dialysis treatments, a couple of times a month, maybe once a week, they'll pass out either an Edmonton Symptom Assessment Scale renal or an integrated palliative outcome score renal, and really have the patients fill it out, maybe with their families, and then the nurses will take a look at it before the nephrologist or nurse practitioner rounds, and then they will have identified the 2 or 3 symptoms that are most troublesome to patients. Have you had any experience with that?
Yeah, there is the pain assessment that was, and depression assessment that was mandated as a part of what the kidney center needs to be doing. And just looking at that process and how it impacted our dialysis staff in terms of the operations and, what they would be doing. I wish that it would have been the right time for us to do that. but it really wasn't. And so, I think part of moving the needle in terms of supportive care is also seeing like what are people ready for, and where to push, where to pull back a little bit. Where I certainly am still learning those lessons every day, but I think that's part of it as well. I think that I would ideally have had some big package that would change everything. At the same time, we're talking about organizational and cultural change, and so what are the bite-sized elements that really challenge people, that get them activated, and at the same time, it's not too overwhelming for folks.
Yeah. All right. Last question. Just a minute left. Are you optimistic that you're going to really be able to train dialysis center personnel in primary palliative care skills, or do you think that dialysis centers and nephrology practices will have to adopt an approach used otherwise? We know that large nephrology practices now have an interventional nephrologist and they have a transplant nephrologist. So they basically develop subspecialists to deal with the different aspects of nephrology patient care. Do you think every large nephrology practice is going to need a palliative care nephrologist in the future? Will that be the way that we go?
I don't think that either of those strategies is mutually exclusive. In fact, I think that you're going to need both. When we're looking at the sheer numbers of patients and their needs, we need to, if the goal is to really provide patient-centered, goal-concordant care, everyone needs to up their skills, up their game, and that includes even the subspecialist, kidney palliative care staff member. We're going to need to adapt to what the organizational needs are, and at the same time, the organizations are going to need to say, this is important, this is the right thing for patients and families, and this is what we're going to do to invest in primary palliative care. I do think that, that we are seeing a movement towards subspecialization within nephrology practices, and I think that there is going to be a need to develop essentially a kidney palliative care champion. They may not necessarily have gone to palliative care fellowship, but I think having a degree of expertise will be helpful. Just the same way that you might have a glomerular expert or a dialysis expert, CRT expert within your group. I think it would be good to have a kidney palliative care champion within the group as well to provide the best care possible.
Good. All right. Well, thank you ever so much. Sherry, I'm going to turn it back over to you for final instructions.
Thank you, Woody. Thank you, Dr. Lam, for sharing with us today. On behalf of the Coalition, we hope that you all have enjoyed the presentation and found the information beneficial. The webinar has been recorded and will be available on Kidney Supportive Care supportivecare.org in a few weeks. And as you're leaving today, please be sure to fill in the evaluation that will pop up in an additional browser as you're closing out. Your feedback, again, is important to us. Thank you again, and please reach out to me if you have any questions or concerns.